Thank you all for having me. Thank you, Eamon, for the kind introduction. I'm incredibly excited and lucky to be here. It has been a great trip thus far, and I'm so looking forward to talk with as many of you as possible afterwards and learn from all of you. I'm able to give 2 talks today. I already told Eamon that I made the executive decision to have the first one a little bit shorter, the second one a little bit longer. I hope I'll stay in time and we have great discussions. The first talk is focused on clonal hematopoiesis and the deriving forces, what makes it more likely to go into hematologic malignancies. As you all know, this is just a little bit of introduction. We are all in the field. The classification of AML is based on the morphology of the leukemic blasts, on cytogenetic abnormalities, but also on gene mutations that are recurrent. And that was, for the longest time, how we also classified the disease. In 2022, when the WHO made its new classification of myeloid neoplasms, as well as consecutive clinical guidelines such as the European Leukemia Net or the NCCN, there was really a drastic shift in 2022 that since then continued. It has been recognized since then that the spectrum of myeloid diseases is really fluent. It's not that, and that makes a lot of sense, and I remember back in, it was 2014, being with Dr. Bloomfield at the earlier WHO meeting. Some of the earlier thinkers like Ross Levine, Ben Ebert, back then already pushing for a molecular-driven classification, but the time wasn't ready then. And now I think it is not entirely clear how the gene mutations drive through the myeloid spectrum, but everybody agrees that this is what drives the disease. And so we now, and this is, it's not a perfect graph, but it's like how I like to think about the disease, is that it really starts with CHIP or clonal hematopoiesis, where you only have a mutation, you don't have any changes in your blood counts, you don't have any dysplasia. As soon as you have the unexplained cytopenias, we're talking about CCAS, so clonal cytopenias of indeterminate significance. And then as soon as you also have dysplasia, as soon as you have dysplasia seen, this is when we talk about MDS. And then, of course, with an increase in blasts, but not only that, we can talk about AML. Here, and I think this complexity, this is what makes it challenging for all of us, and to see when is the best time to treat our patients. For example, in order to be classified as AML, some of these genetic lesions classify you as acute myeloid leukemia, even if you only have a blast of less than 10%, for example, if you have P53, similar as we did it for decades and decades for core binding factor lesions. So I think if we think about our myeloid neoplasm spectrum in this way, the question comes up, what even is, and is there such a thing as normal hematopoiesis? Because what happens, and if this is what is true, is that we anyway all accumulate these mutations in our hematopoietic stem cells over time. So at what point is our stem cell not normal anymore? At what point are we talking about disease, and at what point are we not doing that? And what we try to understand, and what this really exciting field is like, what are the drivers if we have these mutations that make it more likely or less likely for a patient to develop a myeloid neoplasm? We know that, and I'm going down here through the different parts, which is clonal hematopoiesis, CCAS, MDS, and AML, that there's not only a stochastic drift and an immune selection, but there are also other pressures from outside. For example, chemotherapy, aging. We know that smoking and exogenous stressors are very important. And everything at the end, in some way, and that's going to be the main topic of my talk, links together to an inflammatory profile and deregulated immune response in our patients that is in one way driven by the clonal cell population itself, and then it is developing a feedback loop with the immune microenvironment that then increases the inflammation within the bone marrow. So we know, as I mentioned, that aging, immune-mediated selection and therapy can be such pressures in here. And we know that it also matters what kind of mutation we have. For example, the classic DTA mutation, DNMT3A, ASXL1, and TET2 make it much more likely, as well as having a TP53. And there's also an association with a variant allele fraction. And you can see really here that the mutation fitness is dependent on this genetic context. There are also clinical approaches that are supposed to help guide us when we see patients in our clinic, actual scoring system that I'm going to talk about, where you can assess the likelihood of your patient that would present with CCAS in most cases when you see them. And one of them is, as you can see up here, the blood counts. If you, for example, have an increased mean corpuscular volume, very on the top, that really increases your risk that something is going on in this marrow, even though you do not have a dysplasia at this point. It is the mutational burden, and as I said, the clonal burden and the mutation type. So each of these steps, starting from CCAS, actually even earlier in CH, and especially also from MDS to AML, is driven, as I mentioned before, by inflammation and deregulated immune response. And some of the data that supports this, I would like to show you, and this is work that was done in both pediatric AML patients as well as adult AML patients, led by Tanya Gruber and Yannis Eifantas from NYU, and our team was able to participate as well. And what you can see on the left side is a UMAP presentation of a single cell-based AML cells of both the AML blast as well as the microenvironment. And you can see that a lot of patients were included in these analyses. And what the investigators did was that they derived a differential gene expression profile and were able to separate the malignant cells from the microenvironment. The malignant cells on the left-hand side that you can see are red, the microenvironment is yellow. And when you looked specifically at the malignant cells, you can see an increase of inflammation. This is very, if you compare it to normal cells, and that is very apparent not only at the AML stage, but already if you then integrate these data with the malignant cells from MDS, as well as the clonal mutation harboring cells from clonal hematopoiesis patients. You can derive a signature out of those genes that where you see which are the genes that are actually upregulated. At the end, these were 246 genes, and if you condense them down to a signature that they called I-score, that is really something that was classifying all the three diseases, AML, MDS, as well as the cells in clonal hematopoiesis that harbor the mutations. And you can see that it's not only the malignant cells that are shifted, or the precursor cells, but it's really the entire microenvironment that is changed at the stage from clonal hematopoiesis on, where you can see different populations, for example, of atypical monocytes that you usually do not see in patients who do not have any myelodysplastic disorder or clonal hematopoiesis. We know that there is an age-dependent cell response, so we see a little bit of different microenvironmental shifts if we look at pediatric patients compared to adult patients. So there is a component, but the general principle of inflammation is the same in our patients if we talk about pediatric versus adults. So what about this I-score? And I am very excited about this idea to have something that we can try to track to understand inflammation better. So this is work that was done by Martin Fornerit from Erasmus. And one of the questions we had early on was to say, okay, perhaps inflammation is just a surrogate. You know, if you have a certain subtype of AML, let's say with FLT3, with TP53, perhaps you're more likely to have high inflammation. And this was exactly the case. If on the left side, you could see it in a Tisney plot, where Martin annotated a lot of the different driver mutations in AML. And on the right side, you can see if the more red a dot is, the more inflammation or a higher I-score this patient has. It is enriched in certain molecular subtypes. But that's not it's enriched, but it's not a complete association. So having a higher or lower I-score, higher or lower inflammation is important in any genetic risk group, and this is just stratified by ELN. And if you look both in adult as well as pediatric patients, if you have high inflammation, especially if you look here in the favorable risk group, this really separates out. These are patients with the same molecular profile. If you have this high immune response, you do significantly worse, and your likelihood of progressing from clonal hematopoiesis to MDS to AML is significantly higher. So inflammation plays really an important role in shaping the AML microenvironment, and there are immune populations that are uniquely expanded in high inflammation patients. There's an enrichment of atypical B cells and age-dependent differences in T cell activation. And while there is an association across the myeloid spectrum with genetic features, it remains diverse and associates with survival. And there's a lot of additional work going on to understand its impact, even post-treatment, because there is emerging data that shows, even though we don't believe that clonal hematopoiesis after achieving a complete remission is an adverse prognosticator, that might very, very well be different if we still have an inflammatory profile at the same time. And this might be especially important in the context of stem cell transplantation. Just a few more thoughts in general. This is not the only way how we think about inflammation and clonal hematopoiesis, because the notion of it comes from outside of the hematology world, which was actually coming from arteriosclerosis, where, as you all know, these publications, clonal hematopoiesis and the risk of arteriosclerotic cardiovascular disease was linked. And a trial was done, there was a CANTOS trial, where patients were treated with an IL-1 beta inhibitor, not at that point to really look at clonal hematopoiesis, but to see if this is something that could reduce their plaque burden and the development of cardiovascular disease. But what the investigators were able to show is that, especially in patients who had a TET2 clonal hematopoiesis, that in those patients benefited, and this inflammatory response reduction with sanakinumab really improved survival of these patients. Here, just like going through those other data over TET2. So there is something, especially with TET2, that these patients might benefit from IL-1 beta blockade, and there are ongoing trials at several centers that try to see if patients with high-risk CCAS might benefit from sanakinumab to not progress through MDS. This is just once more, like what I found very interesting, that's additional unpublished work, where Ellie Pepper, Manuel, Dan Landau, like a group from New York, has been looking at clonal hematopoiesis patients. And these are two patients, and I want to point two things out. There's patient number 1 and patient number 2. One patient has an IDH mutation, the other one has an IDH and an SRSF2 mutation. These were patients who are supposed to have clonal hematopoiesis with variant allele fractions of around 10%. But if these are bone marrow slides, and what you can see is that almost all their cells already harbor the mutation in the bone marrow. Usually you don't do at the stage of bone marrow aspiration. And you can really see that there is a founder clone that has sometimes individual mutation, but also shared mutations in here. So we can track them over time, and this is just, again, if you then look at these cells that harbor the clones, the one thing that stands out is this aberrant inflammation in them. So there are a lot of exciting questions in different areas that we can answer. We really have to understand how inflammation drives disease transformation. Does it drive treatment response? How about the relapse risk in genetic subgroups? And could we target inflammation in AML or in earlier stages? And also really think about the context of allogenic transplant. Yes, that's the different three things: stratification, response, and transplant. It's also one more train of thought in here is that the one disease subtype, if the disease progressed as myelodysplasia-related AML, I'm sure we talk more about this part in here, where this is this very new category going through, and many of these patients come from clonal hematopoiesis. And there we know that inflammation is very important, and that might be a subgroup that would benefit especially from early intervention. So what can we do to break this clonal hematopoiesis inflammation expansion cycle? One provocative thought at the end, and I'm showing this data here from the Scandinavian research group. This was a late-breaking abstract from the European Hematology Association, just presented 3 months ago in Frankfurt, no, in Madrid, in here, is that the Scandinavian investigators used low-risk neoplasms as well as CCAS patients and treated those with vitamin C in high doses. And what they said, and that was very provocative in here, was that the patients who received vitamin C, especially when they had clonal hematopoiesis and low-risk MDS, had a lower risk of disease progression. So I think we have to think a little bit outside of the box, really consider this immune system even in the early stages. And I think there are a lot of outside-of-the-box opportunities for us to help our patients. Thank you.
Thank you so much, Dr. Eisfeld. So maybe we have time for 1 or 2 questions, please, if anyone. Nothing? Okay. Maybe I can ask a quick question. I know I have some interest in the global impact of genetics in AML. Do you think these data has always needs to be validated in different areas all over the globe, Asian?
Yes, and that I will go into that in more detail. Thank you for that question in my second talk, 100%. Because if you think about inflammation and inflammatory response, it will be, there's one intrinsic proportion, and then there are external stressors. And I think about the microenvironment and the macroenvironment, and where you live and what you go through in your life will determine how this inflammatory response is. You have the food that you're eating, the differences in the diet, all of this, and that's what I think makes it so exciting. So how much can we change? But the main thing is, what all do we have to do to understand it? And I don't have the time to go into all the details, but from the studies that we did, we know that it is incredibly different. The inflammatory response is very, very, very different, for example, in African American and African patients, those patients from Mexico, Brazil, and even from some other countries that are usually not as well represented. So the more we can do to understand it and really have a global approach to understand it better, I think that will again be better reflected of all of our patients.
Thank you so much. Mm-hmm. Thank you, and look forward for your second talk, Dr. McKay.
We have another question.
One more question? Yes, Dr. Hannah.
I'm very happy you mentioned about the inflammation and transplant in pediatrics with a disease called SOHO. We actually, when we use hematolimab or gamma prior to transplant or peri-transplant, it decreased the risk of graft rejection significantly, even if we thought traditionally that the disease was under control, but decreasing that interferon gamma seems to help tremendously in the transplant outcome.
Yeah, thank you for saying that. And we see, and especially I'm excited about this idea of having these more specific parts. I mean, you know, since decades we have been using steroids, which are very unspecific, but having the opportunity to tailor it more and see what are the actual interferons, you know, that we want to target and which give us more side effects, you know. I think this is going to be a really exciting opportunity and really for doing transplant questions as well.